Hello everyone, I'm Dr. Darsha.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
Before we get into the show, let's talk about this week's sponsor, Deputy. At your practice, what happens when staff call out sick? How much time does it take to find replacements who can fill in? If you need to cancel appointments because you're short-staffed, what does that cost your practice? Deputy is a simple app that's helped more than 250,000 workplaces tackle this problem. Deputy makes it easy to schedule staff in line with patient demand, communicate schedules with your team, and instantly find replacements when someone calls out sick. To learn more and try Deputy out for free, go to drpodcastnetwork.com/deputy.
Charlie Piermarini is our guest today, and he is a physician assistant in pain management. Now, while obviously his patients are suffering in pain, he started to notice a trend that CBD would take care of their pain. And so he decided to become an expert in cannabis, and he started his own company called RestorativeCBD, which not only provides CBD to consumers, but also provides education to patients and healthcare providers. As we all know, CBD, medical marijuana, the use of it is being used in so many different ailments, from sleep to anxiety to cancer patients. And so in this episode, we delve into all of those different things. We first touch on the history. Where did cannabis first come from? Why were there so many limits on it? Why is it a Schedule I drug? And why is it now becoming legalized? We then touch on the differences between the molecules, right? I think a lot of you have heard of CBD. Well, how is that different than hemp? Or what is hemp? How is that different from THC? It can definitely become confusing, but we lay it all out. We then talk about the cannabinoid system, this inherent system that we all have. And it's the same system that will actually give you that runner's high. Well, we talk about why it's so important and essentially how CBD and THC affect the receptors. We then go into all the different benefits of cannabis in different ailments, such as sleep, nausea in cancer patients, appetite, and definitely pain and inflammation. So this is definitely an awesome episode. I highly recommend you stick through it all because you guys will come out as almost cannabis experts. And again, check out Restorative CBD if you truly want to become an expert. All right. Hello, everyone. Welcome back to another fantastic episode of Medicine Redefined. Today, we got a special guest, Charlie, who is an expert in all things cannabis. And I'm really excited to delve into this topic. Obviously, it's a hot topic. We're seeing cannabis get legalized across the country, but we're also seeing maybe its benefits in healthcare and how patients can use it. So, Charlie, how you doing, man?
Good. Thanks for having me, guys. I really appreciate it.
Yeah, absolutely. So, Charlie, if we can just start off, well, how'd you even get into cannabis?
Yeah, great question. Kind of like most medical professionals, right? Kind of very limited knowledge about anything cannabis or CBD, and I've been the last 6 years in pain management and just seeing a lot of patients coming in. You know, patients are taking it upon themselves to find anything that will give them any type of relief. So I had a lot of people coming in with bottles of CBD, and I had no idea what it is. I thought it was THC, honestly. And so it wasn't until I had a few patients come in with some life-changing results, some of them coming in handing back their bottles of medication, opioids, and some of them asking to be reduced, some of them going from, central pain syndromes, which are very difficult to treat, to, walking and talking and just, life-changing results. And I started taking this serious, started researching in PubMed, and lo and behold, there's as of right now, there's over 4,000 articles on PubMed with, cannabidiol as one of the headers. So, just really have made it my mission now to really educate our patients and the medical professionals about this amazing plant.
That's awesome, man. That's a scene to see, patients giving back their opioids because CBD is working. I mean,
Right.
Altamash and I are in PM&R. Right. One of the things we often prescribe are, opioids, oxycodone, all these things.
Right.
And I'll give it to a lot of patients. They don't want to end up taking it, but to hand back a bottle of this is pretty cool.
Right.
So I want to get into the history of cannabis because I think it's such a cool topic that I think there's a lot of misinformation out there. And I think I first heard it on Joe Rogan. It has something to do with paper and the paper industry. Is that correct? I don't know.
So if you really want to go like really far back, yeah, hemp has been. I mean, there's pictures of some of the first money ever printed was printed on hemp, and also there's pictures of farmers farming hemp on some of the very first actual dollar bills, maybe $2 bills that were printed. I mean, all the way back then. Thomas Jefferson, all these guys. Some of there's rumors that some of the copies and some of the Declaration of Independence was actually written on hemp paper. Um, and hemp's been around, longer than we have, and it's just gotten such a bad rap, and it's all because if you really trace this back to um, really 1900s, there's prescription paper pads of physicians writing marijuana and THC tinctures for anything from nausea. I mean, the Queen of England was one of the first people ever reported to use it for her endometrial and nausea pain related to her periods. And so she, fast forward to what really killed the industry. Two things was the taxes that they imposed on it, and a little company called Bayer invested a pill called aspirin.
Mhm.
And so patients like to take a pill rather than dosing a tincture. So it's way easier to take one or two pills and then come in the morning rather than here dose this tincture by this and try that. And so that really killed it. And then the whole war on drugs with in the 80s that just really
Yeah.
put the knife into the heart. But it's had a very convoluted history from the start. I mean, even from Dr. McCollium, who's from Israel, where all of the research is done. I would say most of the research is. He actually stole one of the plants that was confiscated to actually study the cannabinoids. So even the legitimate research is kind of founded in illegitimacy,
Okay.
and so it's just a very interesting field.
You know what's interesting? I heard Dr. Andrew Weil talk about this, I think, because he's one of the, few that in the 70s and 80s was trying to look at marijuana, but he was saying the government would
Right.
only let you study marijuana if you found negative side effects of it.
That I can't speak to that, but it only makes sense because they have the marijuana actual the patients that were getting marijuana is coming from a single farm in Mississippi, and it was highly regulated, highly controlled, and it doesn't represent what the plant is today. But yeah, I mean the government just had Nixon when he did his war on drugs, and all of those, all the previous presidents and all of them leading up to him, they actually commissioned a drug task force. And actually, if you look at what they said actually marijuana doesn't really have that many negative side effects to it, but they still banned it. They still put it as a controlled one. Basically no medicinal benefit, just like heroin, cocaine, meth, all these things. So we're slowly seeing it turn the tide since, in the early 90s, the government actually owns two US patents on cannabidiol for anti-inflammatory and I think neuropathic pain. They own the two patents on it. So what do they know that we don't know, I guess? And so cat's out of the bag. It's changing, especially states are now becoming legal. It's a matter of time before it's federally legal. I still think that's got some hurdles, but I mean, Canada, it's legal. Mexico just made it legal. So it's just a matter of time.
Charlie, I want to stay on this thread of the legality of it,
Yep.
right? I mean, you kind of just alluded to the fact that federally it's different, and then state to state there might be some different aspects that we're looking at. But I think let's take a step back really quickly and kind of just make sure that the terminology is all ironed out, and so we're not using them
Uh-huh.
interchangeably. You mentioned hemp. We're talking about cannabis. We're going to touch on CBD, THC. Are these
Right.
terms interchangeable? If not, then what are the differences?
Dude, great question. So cannabis is the overarching term, and so cannabis is the umbrella term. So hemp and marijuana are brothers. They're both considered cannabis. The only thing that differentiates them is the federal government labels industrial hemp anything containing 0.3% of CBD by volume or less. That's hemp. And hemp typically has higher volumes of CBD in it, which is the more medicinal part of the plant. And so cannabis can both be marijuana or hemp. But as full disclosure, I own a CBD company, so all the CBD products are derived from hemp. But I also coach patients on cannabis, so um, that's a good point. They're not one and the same, but they're very similar. They're related, but marijuana is basically the two major cannabinoids are CBD and THC in both of marijuana and hemp. It's just how much the percentage for each of them is.
Yeah, no, thank you so much. I think that's super important
Yeah,
for us to kind of appreciate. And then,
right.
with respect to the legality of it, again,
Hmm.
as I understand, at the federal level, it's illegal. But then, obviously, certain states
Hmm.
have recently passed the law that at least the recreational use is legal. Talk a little bit about that.
Right. So that makes it super challenging as medical providers for us, right? I've worked in pain management similar to you guys for the last 5, 6 years. And if we tell our patients that our DEA number is a federal number, right? So we're regulated by the federal government, even though in the state of Arizona, it's both recreational and medicinal here. So you can walk in as an adult and get marijuana if you want. And you can have a card and have it too. And you pay different prices and there's some different protections. But basically what I tell patients is legally, if you're getting opioids, which is a controlled narcotic, you shouldn't be having any THC in your system, even though there are studies that show that concurrent use of cannabis with THC, with opioids patients use less opioids. But, we're stuck in a rock and a hard place, especially someone like me who is a big believer in cannabis and coaches patients on it. I can't, legally be writing you opioids if you're having THC in your system.
Mm-hmm.
There is a loophole. Some of the pain docs I work with and how I practice is we see a lot of cancer patients, terminal cancer diagnoses sometimes are, there's a little bit of leeway if someone's got, pancreatic cancer and they got 6 months left to live. And the only way to eat is smoking some cannabis, that's a whole different story. It's just, I think in the next couple of years, it's going to change for sure.
Gotcha. So are you allowed to prescribe full spectrum CBD then to people who take these pain meds?
Yeah.
Okay. And if you can you just explain the difference between? Oh, go ahead.
Yeah. So still full spectrum? No, because full spectrum has 0.3% THC in it.
Okay.
So it'll show up in your urine. And so I tell all of my patients, all my coaching patients, everywhere I lecture, I said, if you are worried about popping positive for THC, either for your job, for religious reasons, or for your pain clinic, you should avoid any CBD products. So we use a 99% pure CBD isolate for some of my products, but what does that leave? Another 1%, right? Potentially with THC, it's non-detectable THC, but if you're using higher dosages for longer periods of time, there are reports that people are popping positive for THC. So full spectrum products, I tell my patients, if you're on opioids, you got to avoid full spectrum. And, if you're coming to me and you're on a CBD isolate, if you do pop positive for THC, we have to either stop the CBD or you have to stop the opioids. You can't have one or the other. I can't have both at the same time. It's one or the other. So it's, kind of put in difficult situations here. And I know you guys understand it too. And it's sad because some of these patients get such great relief. I've got a guy that's getting CBD. He was using kratom until we started, the urine drug screens are now starting to pick up the kratom, and we don't know what kratom is, right? But the opioid properties of kratom and, plus his Percocet plus his CBD. So he was kind of, these patients get into kind of a bind.
Mm-hmm. So what's the difference then between full spectrum CBD, broad spectrum, and then the isolate?
Good question. So full spectrum is basically if you took the bud of the plant and you crushed it and you got the oil out, that is the full spectrum. The full spectrum contains all of the over 700 active ingredients within cannabis. There are over 120, I think, active cannabinoids. They're finding more every year. And so the other thing that people don't realize is the full spectrum products contain all of the terpenes, and terpenes are becoming very, very important. They cross the blood-brain barrier. They have a lot of properties, pain relieving, anxiety, sleep, depression. And so when you have a full spectrum product, you have the most real and the most natural product. And then the step down to it would be a broad spectrum is basically when they remove THC, try and keep as much of the other cannabinoids in it. And then an isolate is basically isolating any one of those molecules. We can isolate THC, we can isolate CBD, you can isolate CBG, CBN, all these types of molecules. And that's kind of the hierarchy of how this works.
Now, Charlie, obviously, this is a pretty complex system. We're just kind of scratching the surface and early in this conversation, but
right.
I think that it has a tremendous value and lots of different properties. But I think for our purposes and our conversation, we're looking at the medicinal aspect, right, and trying to keep this conversation as scientific as possible. And I think no conversation in science can truly be appreciated unless we understand the mechanisms behind things. So I'd love for you to kind of explain what the endocannabinoid system is, and then also how are these different formulations affecting that system, whether either upregulating or downregulating. Talk a little bit about that so we have an idea.
That's a great question. Endocannabinoid system is, a very, very complex system. A lot of people have a tough time relating to it because, cardiovascular system, heart and lungs, people know what those are, but the endocannabinoid system is a loose collection of receptors, neurotransmitters and enzymes, very similar to the endocrine system, right? And so it's a lot of harder for lay people to kind of wrap their head around it. But basically, the endocannabinoid system, endo meaning within, cannabinoid meaning relating to cannabis-like products. So we have a whole system in our body that basically binds products exogenously or from the outside, but we also produce two carbon copies of CBD and THC naturally in our body that bind these receptors. And so the endocannabinoid system is charged with what they call homeostasis. And so homeostasis is basically just keeping you in a specific regulatory environment. Our body keeps our blood, our gas levels, our pH levels, our respirations, everything in a very tight window. And the endocannabinoid system is charged with being the supercomputer. It's basically the brake pedal to the gas pedal to all these other systems that are kind of trying to make things go. This kind of slows things down. And so it gets overrun with our, Western diet, our lack of sleep, our lack of exercise, our bad diet. And there's clinical endocannabinoid deficiencies that Dr. Ethan Russo talks about, but the system is incredibly complex. We're just really learning about it. We only really discovered it in the 90s. Basically, we radioactivated tagged THC when someone took it, and we saw all these various receptors. And so the endocannabinoid system is comprised of two main receptors, CB1, which is primarily found in the brain. The only reason they named it CB1 is because the first one that was found. CB2 is on mostly in organs and immune system, mostly in the immune system. And there's a new one that they're calling CB3. It's the GP55, I think. It's an orphan receptor they think is a cannabinoid receptor. But basically, what also complicates this issue is when you take exogenous or an outside product, CBD, THC, cannabis, hemp, whatever it may be, these products don't just bind within the endocannabinoid system. They are hitting serotonin receptors. They're hitting opioid receptors. They're hitting TRPV receptors, which are big, the vanillin receptors, which are big in pain management. They're hitting capsaicin. They're hitting the PPR gamma receptors, which actually upregulate and downregulate gene expression. Is an extremely, extremely complex system. Then you start layering on the fact that there's specific enzymes breaking down these endogenous or are naturally produced CBD and THC, and those sometimes become overregulated, kind of similar to what I tell patients when you take CBD. It's very similar to Lexapro or SSRI, downregulating some of the enzymes that are maybe overworking too much. And then the beautiful thing about the endocannabinoid system is it takes signals out and it pushes signals back in too. So it's an afferent efferent system, and also one of the only systems that we know in the body that actually does retrograde inhibition in the nervous system, and that's why it's very big in seizures. And that's why Epidiolex got approved by the FDA for seizures. It's a beautiful drug for seizures. There's a whole litany of stuff on that. There's shows and movies, but the system is extremely complex. There's set enzymes that actually break down endocannabinoids, which are made on demand from the lipid bilayer. And then there's specific enzymes that are breaking it down on the other side. But I mean, now you're talking about not just one system. Now you're talking about something that's hitting multiple systems, right? And it's extremely complex. It's charged with a lot of stuff. We're still just learning about what this is doing,
Right.
and it just what makes it so fascinating.
So, with the exception of CB1, I'm sorry if I missed this, the rest of them in their
Very good.
peripheral, or they're all central nervous system?
So mainly CB1 is central. CB2 is mostly peripheral, but it doesn't mean you can't find them, in the same places. But there's even CB3 receptors they're finding more at sites of injury, like a broken bone. A lot of endogenous endocannabinoids are released to help with bone reformation, and so it's an extremely complex system.
So that would kind of explain the concept of why you have the the psychoactive component of THC, because my understanding, at least just from doing a little bit of homework, is that THC will primarily affect the CB1 system, right? Whereas CBD will affect all the other systems, kind of as you already mentioned. Now, what I found interesting was, and please verify this, that CBD actually opposes the action of THC at the CB1 receptor as well, right? And so that's why it can help counteract some of those, adverse effects like cognition, memory, psychosis, that kind of stuff. Is that true?
Yep. That's an amazing point. And there's so many things I can go off with that, but basically THC preferentially does bind the CB1 receptor. And so what I tell patients is in my lectures that I give is basically, site of receptors determine function, right? CB1 receptors are found in the amygdala, hippocampus, right? Prefrontal cortex, all areas for memory, emotion, and your cognition, right? So if anyone's ever smoked any marijuana in their life understands that you get either happy or sad, you get hungry, right? And your judgment's a little bit off. It's because receptors are located specifically in these parts of the brain, and THC, like you said, preferentially binds CB1. Now, when you start throwing in CBD into the mix, is CBD is what they call an allosteric modulator. So it doesn't bind specifically in the receptor site that THC does. It binds off of it, changing the complex a little
Mhm.
bit and kicking THC off, so it's not binding as hard as fully. And so a lot of patients that get too high, they'll call me. I said, you know what? It's going to sound counterintuitive. Take some CBD drops and give it about a half an hour, and lo and behold, they're like, oh yeah, it's way better. Yeah, because it's changing the conformation in your brain, and that's what's the problem with these. Not to digress, we'll sure get into this, but a lot of my patients that go to the dispensary, they're 75-year-old grandmas. They're looking for stuff for their back pain, and they
Mhm.
go to the dispensary and they're getting stuff that's super high THC, and there's no opposing CBD, and they're on the moon, right? And they're like, well, that sucked. I'm never using that again. I'm like, well, just give it a shot. You got to use this a low and slow type of approach. But yeah, I mean, just explaining that whole process, right, is like super complex. And then you can get into the fact of THC binding beta receptors, right? And that's why there's heart
Mhm.
rate elevation when people smoke. I mean, it's extremely complex.
Right. And I mean, the best part about it is, and the other thing I will say, we don't have even a fully grasp. I mean, we haven't grasped all the concepts, right? I mean, we don't have a clear understanding,
Right.
and we're still learning. I mean, I know
Right.
you mentioned there are several
Right.
thousand papers out there, but I think I please correct me if I'm wrong on this. A lot of those studies aren't randomized controlled trials, and they're not human trials. Is that correct?
Right. Right. You're
Yeah.
100% correct. And that's what I fight against a lot of my medical colleagues that are, where are the randomized controlled studies? Where are the randomized controlled studies? Because that's what medicine is, right? Randomized controlled
Yeah. Unfortunately.
crossover studies, right? And unfortunately, but it's getting there. I mean, look at where we've come from 5 years ago, right?
Hmm.
Cannabis dispensaries and CBD stores were deemed essential during the pandemic. I mean,
Hmm.
you'd never thought that 5 years ago. So the randomized control studies are coming, and they're being done right now. And unfortunately, the people that can afford it are big pharma. And so, companies such as myself and the other CBD companies, I just don't have the money to run a randomized controlled
Hmm.
study and donate
Right.
thousands of bottles of CBD. So
Yeah.
it's coming. It's just going to take some time.
Yeah. I mean, change always does, and I think you don't. I
Right.
mean, nobody wants to rush the process. Well, some people do, right? I think that maybe if you feel like it, I know that on your show you talked about the bad actors who have the wrong intentions at heart, and they're doing it for
Right.
their own. They're not doing it for the science reason. They're looking at it from a business perspective, and
Yeah.
understandable. But I think that you just need a few bad apples, which we've talked about at length on this show. You mentioned earlier that large doses, even if you're taking a CBD isolate, can give you a false positive, right? What kind of
Yeah.
doses are we talking? Are we talking milligrams, micrograms? What are we talking?
Milligrams. So
Okay.
it'll most likely be anything. I mean, consistently over time, cannabis and THC are fat soluble. So it'll be stored in your fat. And basically everyone's endocannabinoid system processes these things different. We can get into the gut biome and that absorption properties. But I saw a paper once, I wish I would have printed it out, about people taking CBD and the gut bacteria, synthesizing CBDA, which is the carboxylated portion of CBD, and you can sometimes be positive for THC. But also, we know as medical professionals that point of care cups are not they're not PCR tests, and so it's looking for anything that is similar as a cannabinoid, right? THC and CBD are similar enough, right? And so there's different isomers of THC. There's delta 8, delta 9, delta 10, THC 0, THCV. So sometimes it could be you're not even taking T8 delta 9, but you're taking something that has a full spectrum product that maybe just has THCA, which is non-psychoactive, trips off but usually patients that are taking 100 milligrams or more consistently will have a chance of testing positive. So again, I tell patients, like, even topical products, I've seen patients come in that I trust and they're like, I'm only using this topical product, it works. Yeah, you're positive for THC. They're like, well, the bottle says there's no THC in it. I'm like, well, there's THC somewhere. And so, you got to stop it. But you got same conversations I'm sure you guys have every
Yeah.
day. So
Yeah,
Right.
no, it's important, and I mean, as many times as it takes to kind of continue educating the masses, I think that's what it's all
right.
about. Before we switch gears from the mechanistic, understanding that, just to further develop that, talk a little bit about if you don't mind, about the pharmacokinetics. So you mentioned topical. That's one mode, right? I mean,
Hmm.
there's edibles, there's tinctures,
Hmm.
all that kind of stuff. I think that you touched on. How quickly does it act, and what are the differences?
Yeah, great question. So uh, the best best way to deliver cannabis is inhalation, right? It's the quickest and it's the most absorbed. Um, I have a tough time being a medical professional and telling patients to go smoke joints just because, or vape, or, especially with all the stuff that's going on with vaping and all that stuff. So I really avoid that. But I think it's 40 to 50% systemic absorption with smoking, and the onset's like 10 to 20 minutes, and the offset's, an hour or two. The next level would probably be a tincture, a sublingual tincture. Anything under the sublingual, the tongue is full of that, the venous plexus, which is able to absorb it. That is anywhere from 20 to 30 to 40. I've seen some literature kind of all over the place. And that is going to be a little bit of a slower onset, 45 minutes to an hour. That's going to be a little bit of a longer, around kind of couple hours. They say oral CBD can be dosed anywhere from Q8 hours. So, 3 times a day ish. I tell patients every 3 to 4 times a day, depending on what you need. Topicals are absorbed, right? Systemic absorption is lower, but it's still there. And then gummies, like edibles, are like 33% of the market right now. Those are slowly absorbed. The absorption rate is much lower, and I don't recommend those for like pain patients who typically need a little bit higher doses. So, even the research, even the literature, I've got textbooks here Dr. Andrew Weil wrote the foreword to Cannabis Pharmacy, right? And I've got his numbers from what they're saying for pharmacokinetics is different than some of the stuff you find on PubMed. I mean, even published research is still kind of all over the place of what's the systemic absorption, what's the pharmacokinetics, and it's so variable.
Yeah, Charlie. And, the other thought that I have, let's just take aside the whole vaping related lung injury and that type of stuff.
Right.
But, as just a clinician, if I was thinking about it, you mentioned earlier, just if somebody is inexperienced and completely naive to this, and you want to just, again, start low, go slow, kind of, you mentioned, titrating the dose of something that's being smoked. I mean, that would be, how would one even go about doing that?
Yeah, so I've talked to some other cannabis clinicians, and a lot of times what they'll do is actually tell patients to smoke one puff, wait a half an hour, see how you feel, and go up or down from there. And then sometimes they transition them to an oil or a tincture. But that's what's beautiful about cannabis medicine is it's very specific to the patient. And so one puff for you may make you super high. One puff for me doesn't do anything. And so low and slow. And basically, this is why I think cannabis has a tough time catching in mainstream medicine, is because a lot of practitioners are used to, we can write a script for Percocet 10 milligrams, take it 3 times a day. You know the dosages, you know how it's going to work. I tell you to take 10 milligrams of a tincture 3 times a day. It may not be enough for you, but it may put, your friend on their ass. So it's a very complex structure. And I think either vaping to start or tinctures to start at a very low dose, anywhere from 5 to 10 milligrams, is kind of where patients should start.
Yeah, and I guess, not all puffs are created equal, right? I mean, what are we talking?
Right.
1 second puff. So I think that for me personally, just having some experience with this and dealing with a lot of patients with chronic pain in our world, this is kind of the part that I have a difficult time wrapping my head around. But it sounds like from what I'm getting from you is that's not your preferred method, because it's harder to kind of control. Is that right?
It's harder to control, like you said. Yeah. What's your lung capacity, right? What's your tidal volume? How long are you holding it in, right? So with a tincture, even I've got the compliance with my tincture still are very low, and I have written instructions. I tell the patients where the tincture bottles that I have etched marks on it. Hold it for 3 to 5 minutes under your tongue, swallow it. So it's a little bit better, but I still think it's not perfect by any means. There's a few companies out there that have syringes full of like CBD that you can kind of tick mark down into the back of your mouth. I don't know how perfect that is, but I don't know. It's people. What happens is we get away from the full spectrum products, which is the most beneficial part of this plant. And so I think that's why everyone's looking for the magic bullet, right? How do we put this into a pill? But that's not what this thing is about. This thing's about using the most full spectrum product if possible.
Right. And we can complicate even further, right? I think people need to understand that there's different strains out there. There's indica, there's sativa, there's hybrids, right? And you can do an edible, which is going to last longer than, maybe the smoke.
Right.
So it's, like you said, I think it's individualized for sure. And to touch on the vaping, in my intern year last year, I think I had 3 patients that I saw with E-Valley. So what is that? Yeah, e-cigarette, vaping, lung-associated injury.
Oh yeah, yeah,
Um,
yeah, yeah.
and I've seen them with one girl who was smoking out of a vape 2 times a week only for 3 months and developed it. So it's not necessarily
Wow.
people have this association with it, thinking, oh well, you have to be doing it for 3, 4, 5 years consistently and constantly, and well, it's apparently not the case, right? Because you might not know what you're getting out there if you're going black market or something. So it's definitely
Right.
definitely
And what people don't realize is the flavorings that they use for these vapes are cut with random crap, right? And
right.
so even if it's cut with the vitamin E, it should be cut with terpenes and all the natural products. And then what I didn't even realize until I got in this industry was the actual lighting elements inside of those things. The ceramic, are they ceramic? Are they titanium? Are they a whole litany of stuff that I don't even want to get into. So you know, it's a shame that that whole market, people like the bad actors came into that and just made a crap ton of money putting
Yeah.
out CBD vapes really quickly. But I mean, what are we left with? People now, this young girl's got popcorn lung or whatever they call it now, and
Yeah.
who knows what's her prognosis for the rest of her life, right? So
Right. Exactly.
yeah,
Well, Charlie, I want to get back to the endocannabinoid system because I know you mentioned in
right.
your
Let's
book
go.
omega threes, right, and how that also
Oh yeah,
plays a big role in the interaction with cannabis. How does that work?
yeah. So our natural endocannabinoids, 2-AG and anandamide, are actually byproducts of omega-3 and omega-6 breakdown. So obviously, as you guys know, a lot of patients are just deficient in good healthy fats. We like to eat a lot of trans fats because it's nice and easy and quick and it tastes good. But so sometimes this adds to the endocannabinoid system deficiency that a lot of doctors are kind of finding out that it's playing to a lot of these hard to treat diseases, fibromyalgia, migraines, all that stuff. There's a whole, you can look up Ethan Russo's stuff. But yeah, so supplementing with a good omega really make sure that it's also anti-inflammatory, right? But
Hmm.
why are omegas anti-inflammatory? Maybe it's because part of it is because it's feeding the endocannabinoid system, right? Um, I mean, no one's definitively shown omegas anti-inflammatory because it does blocks tumor necrosis factor or whatever it is, right? So I think supplementing with a good omega just keeps your endocannabinoid system nice and healthy.
Gotcha. I think I want to switch gears here now, talking kind of going back to the bad stigmas of things. You mentioned a little bit
Right.
before about what cannabis is approved for. So, what is it approved for by the FDA?
So the FDA has approved CBD, the isolate, for the treatment of a small subset of pediatric seizures with Epidiolex, which is extremely expensive. And I think they just got approval for seizures related to sclerosing cholangitis, maybe, or something, some
Okay.
other crazy small subset of diseases. They're just going after kind of what the orphan disease, right? Stuff that's really hard to treat.
Right.
That's kind of like a Hail Mary. Um, and they're using a CBD that's extremely expensive because it's regulated, right? And they did all the studies. And they're trying to recoup their money. Same CBD that we make in my place for $10 a bottle, right? I mean, but very small subset of what it's approved for. Cannabis on itself is state by state approved medicinally for certain diseases. Pain's usually one of them, right?
Mhm.
Cancer pain, cachexia related to cancer. Um, I think even stuff for like HIV. There's other issues that state by state determines what is medicinal cannabis, but still federally it's still illegal, um, which is wild, right? These states are allowing cannabis to
Mhm.
be written or recommended by physicians, but I think it's the Ogden memo that limits the federal oversight into arresting us for recommending cannabis. But yeah, it's still Wild West, man.
Gotcha. Now, Charlie, I'm curious to know what the conversation is that you have with patients who come in, right? And you say, "Hey,
Hmm.
Miss Doe, I think we should try some CBD for you." And they
Right,
come from a generation possibly where Schedule One, this is illegal. There's no way I would try this. I thought this is what junkies do.
right,
What's the conversation you have with
right.
those patients?
Yeah. I think by the time they come to see people like you and me, they're they'll try whatever, right? And so, but the conversation is, listen, see, you've heard of CBD. It's not cannabis. It's cannabis, but it's not marijuana. It's hemp derived. We're going to start low and go slow. It's a titration schedule. It's a personal dose. And I kind of talk to the patients, say, listen, are you ever tired about just coming to the doctor's office and we writing prescriptions behind our computer, typing it up and send you on your way? this is your way to kind of take onus back onto yourself, because you're able to take home a journal and really monitor your doses and how much did I take and how did I feel and did my pain go away, all these things. So trying to really tell them like, hey, this is your chance to really take control of some of your healthcare back into yourself, instead of just me writing prescriptions for you left and right, or doing shots or injections or whatever it is. So the conversation is not as hard as you think it is. You do get
Hmm.
pushback, but literally just say, here's my pamphlet, here's some literature. If you have questions, I'm here. Go on my website, listen to my podcast. But yeah, definitely that generation, right? Devil's lettuce. It's, marijuana. It's going to get you high. All that stuff. It's there, but you can buy CBD in the gas stations now. I mean, so I
Right.
think patients are just seeing it all over the place. It's on TV, so I think they're open to it now.
Absolutely. Yeah, no, I mean, even in the PM&R world, I know my attendings are starting to learn more about it so that they can have these conversations with patients. We do have
Right.
patients coming in with spasticity, and I think there's actually a big study going on right now in Germany, I
Hmm.
believe, about CBD and spasticity. So, yeah, I mean, it's important for us healthcare practitioners to understand how to approach this conversation, right? It's becoming more and more popular. So,
Oh
100%
yeah.
agree.
And then, but that's the biggest problem about this, is like, we're never taught about any of this in medical
Hmm.
or PA school or nursing school, right? Like, there's a whole body system that didn't even mention endocannabinoid system, right? You didn't even
Right.
heard about that. What the heck is that? So
Right.
just the fact that we can even just mention that word, and people, like the doctors, at least have an idea what it is. That's kind of what
Yeah,
the goal is.
absolutely.
Yeah.
So last week on Instagram, do you know who the psychiatrist is, Dr. Daniel Amen? He does a lot of like brain
I've
scans.
heard of him.
Yeah,
Oh
so
yeah, I've heard of him. Yeah, yeah, yeah.
so he does a lot of the brain scans. He kind of got popular talking about alcohol and like Alzheimer's, and this is what your brain looks like now. And he does a functional MRI. So recently, I think last week, he went on Impact Theory with Tom Bilyeu, and he talks about marijuana and how marijuana decreases
Okay.
blood flow to the brain. And he talks about how he's not really a
Uh-huh.
proponent for marijuana. Just kind of wanted to get your thoughts on
Right.
that. What are your
Yeah, I mean, I think that's kind of I don't want to say a loaded question, but I think one, where the blood flow, what region of the brain is a decrease in blood flow to,
Mhm.
right? How do you quantify it? I still think marijuana doesn't come without any. There are still side effects, right?
Mhm.
You have cannabis-induced hyperemesis syndrome, which has skyrocketed in all the ERs,
Mhm.
right? And if the
Yeah.
listeners aren't familiar with that, it's when you consistently use too much cannabis. Basically, the receptors for basically your emesis, or your throwing up, start to kind of switch off, and you basically just continually throw up. And the only way that you fix yourself is by sitting in a tub of hot water, shunts blood away from your stomach
Mhm.
to your skin, so you don't feel nauseous, right? We don't have to go into the whole physiology of that, but basically there are side effects, right? And it's also, they've done studies and they've shown that the one study that gets misrepresented, I think, is most people say, oh, cannabis causes schizophrenia or causes bipolar. I think the data, if you look at the data, is that if you have an underlying potential issue of developing schizophrenia or bipolar, it maybe kickstarts it, right? I don't think it's causing it. I think it's
Mhm.
maybe bringing that to the surface. Um, and in relation to the blood flow, I didn't see the study. I don't know, but you know,
Sure.
come on, any of the drugs that we give, how come no one's ever published a study about opioids and the amount of testosterone that gets decreased after you take an opioid, right? For half an hour
Right.
after, with increasing estrogen. I mean, there's bad to everything that we do. It's mitigating
Sure.
risk, and it's the right drug for the right patient for the right condition, right?
Is there no evidence? I mean, I'm not familiar with it, but I'll tell you what. Having recently taken my boards, I mean that's tested quite frequently. We talk about that all the time as a known side effect. So I would imagine that it's
Oh,
well
okay.
documented in literature. I couldn't
Which
quote you any studies
which
off the top of my head.
which part? The testosterone stuff?
Yeah, yeah.
Yeah,
The
yeah. Oh
hypogonadism.
yeah.
That's subsequent.
Oh,
Yeah,
huge, right? I mean, that's huge. But so cannabis gets a bad name for potentially doing some of these things, but now we're decreasing people's testosterone. People are addicted to this. People are killing themselves because they can't get it. I mean, so there's always something bad with everything that we do, and we just mitigate risk as
Sure.
providers, right? And,
Yeah.
I think right treatment for right patient for the right condition. I think cannabis is a good option, and I tell patients is it's if you look at integrative medicine with Dr. Weil, right? It's one piece of
Mhm.
the pie, right?
Yeah.
If I'm just I can't give you enough CBD to overcome your bad diet, your lack of exercise, right? Are you meditating? What's your sleep pattern, right? I tell patients, like, if you take just CBD and expect this to be a miracle drug, it's going to fail you. It's not going to work. This is in conjunction with other types of issues that you need to change in your life, right?
Yeah.
And so, you know, yeah,
Right. It's not the cure all, right? I think we've been hitting
right,
that theme over and over, right? You got to get your lifestyle foundation correct first. And these are all
right,
adjuncts, right? To kind of help you get over that hump and make you feel a little bit better.
right,
You mentioned, Charlie, cyclical vomiting syndrome. Now, you're right. I probably treated
right,
about 5 or 6 patients last year with that. And it's tough, right? Because
right,
what's going to help their nausea? They obviously think the cannabis, right? And then you fall into this
right,
cycle. What
right,
have you seen to work when you treat it? Because I mean, we consult gastroenterology all the time on these patients, and it just goes back to using IBS medication, which does not help the patient. And then, of course, insurance companies are like, well, we
right,
want you to try Miralax before, going on to this medication that we know
and you're
will
like,
help. So,
right. So I think with, I don't have any clinical studies with this. Actually don't have any, trying to think, I've never seen any patients with this because
okay,
the patients that I deal with are not abusing it. They're using such lower doses.
sure.
But it all has to do with, right. I mean, what's the nausea reflex? It's from stomach and also in the brain. So the receptors are getting kind of messed up. And so I think absence, right, you're going to feel like you need it more, but I don't have a direct answer for you, but I think people are remiss when, I mean, when cannabis became legal in Colorado, what did they say the amount of cyclical vomiting they saw in the ER in Colorado was like stupid,
Yeah.
right?
Right.
But I think it gets back to the point, right? Every drug, cannabis is a drug. Every medicine that we prescribe has potential side effects, right? Aspirin has side effects, penicillin has side effects, but it's for the right patient, the right dose at the right time can have benefits.
Yeah. So I think that this is kind of a perfect time to talk a little bit more about the therapeutic effects, right? I mean, you've talked about the endocannabinoid system impacting so many facets of basic life. We talked about appetite, immune function, reproduction, all kinds of things. And so, again, a bevy of possibilities for CBD impacting health. But I think that the strongest evidence is probably for epilepsy. You touched on that. That's why the FDA has approved a drug for it. Would you agree? Is that fair?
Yeah, I would say, without being, without being anecdotal, 100% clinical.
Yeah.
Yes, that's the only data that's been published. Right.
Gotcha. So could you? I'd love to kind of start and take a top-down approach with the strongest data, and then we can talk about more about pain and inflammation. I think that might
Right.
be a close second with versus anxiety and sleep, and some obviously they kind of
Right.
all go hand in hand. It's kind of this web that's tied
Hmm.
together. But in terms of epilepsy, again, you touched on
Hmm.
recalcitrant seizures not being treated and not successful and with any other
Right.
medications. And I know you've had several folks come on your show talk about their own personal stories, which have been powerful.
Hmm.
So in terms of how is it, affecting, you touched on the receptors before, but in terms of Epidiolex, maybe we can even talk about that medicine and how it's affecting and treating that specific disease.
Yeah, good question. So if you look at how CBD works so basically, right, for lay people that don't understand, seizures is basically just a electrical storm in your brain, right? I'm not a neurologist, but at the basic level, it's electrical storm in your brain, right? The neurons are firing too quickly, they're not repolarizing, and they're able just to continually fire signals, causing a seizure. The endocannabinoid system has been charged with, part of it is when a neuron sends a signal from the presynaptic to the postsynaptic, going upstream or retrograde, the endocannabinoid system will send a molecule, either AEA or anandamide or 2AG, up, and it takes the presynaptic neuron and it makes it more hyperpolarized, so it can't fire another signal, right? So what happens is when you give somebody Epidiolex, one of the mechanisms that's proposed is basically the CBD in Epidiolex takes the enzymes that break down your natural endocannabinoids that you're making that make this process harder to happen again. It stops them from being as active. Like I told you, like I said earlier, like the SSRIs, kind of similar in that fashion. Um, that's one of the reasons, one of the ways that they think, and that's been proposed, of how Epidiolex works for seizures, because the retrograde inhibition, which is a very powerful mechanism.
Yeah, no, I mean that's, and I would even add it is not only is it an overdrive, but it's also the firing is asynchronous, right? And I think
Right,
that kind of
right,
just messes
true.
up the electrical storm that you talked about. So
Right,
switching on to talking more about pain. I mean, this is
right,
highly prevalent. I mean, even higher than epilepsy. And we talked a lot about opioids, we've been backpedaling for the last maybe decade or two with opioids because we've kind of dug this hole. And so now everybody's on the
True.
opposite side of the spectrum where no opioids, no
Right.
nothing. And we're reaching for everything. Right. And so
Right.
I want to talk about how what the mechanism is, what
Yeah.
the quantity of THC is required in CBD products in order to get a therapeutic effect with this.
Good question. So start off in mechanism. So I'm obviously not, I don't know all of them, but I know the ones that I lecture on mostly are twofold. One, inflammation, right? Decreasing inflammation helps decrease pain for multiple reasons, right? Decreasing nerve irritation. And also the second thing is the CB1 receptors are found in the dorsal root ganglion, right? They're also found in the amygdala and they're found in the hippocampus. So those two things, right? So pain is not just a perception. Pain is also your memory attached to that perception of the pain, right? You
Mm-hmm.
step on a nail, you're like, oop, I know what that is. That's a nail, right? I've had that before. This sucks. This hurts, right? So if you're able to bind these receptors and decrease their activity in the dorsal root ganglion, which is where the pain is becoming afferent, right, into the spinal thalamic, into the midbrain, blah blah blah, gets go to the prefrontal cortex, all these things, right? If you're able to cut it off not only at the site, right, because there's CB1 receptors inside of in your skin and on the inflammatory markers like your white blood cells within your skin that are going to respond to any sites of injury, but also along the track of where these pain signals are going. If you're able to downregulate that and decrease the ability for it to produce its pain signal, but now also you're decreasing, right, hippocampus, which is memory, decreasing amygdala, which is emotion, decreasing, pain is perception. We all know this, right? Your pain is not my pain and my pain is not your pain, but it's also the memory attached to this pain. If you're able to decrease that, it helps decrease some of the pain associated with that. So it's not a magic pill. There's actually physiology and there's many papers published about where the CB1 and CB2 receptors are located in this fashion. And
So
regarding dosages,
go ahead. No, that's what I was
regarding
going to ask.
dosage,
Considering that
uh,
this is the aspect that we're still refining, right? We don't have FDA
mhm,
kind of supporting that. So what
right.
type of dosages and which type of specific formulations would work?
Great question. And the answer is always going to be low and slow, and it depends. And so if you follow Dr. Sulak, Dustin Sulak out of, I think he's out of Maryland, if you do the medical 401 courses, everything is about, some people do weight-based, some people do a low and slow approach because CBD is what they call biphasic. And so if you overshoot your course of where your natural pain relief is, it sometimes can make pain, anxiety, or sleep issues worse. And so you have to go very low and very slow to find your titration, to find your window. And so starting low, starting slow, a 1-to-1 CBD to THC is what is the most recommended thing because, again, we talked about if you have unopposed THC, you're going to get super high. And so the CBD is really important to have. And starting at a 1-to-1 ratio, starting very slow, starting anywhere from 10 to 25 milligrams a day, split up either at bedtime, split up a couple times a day, and doing that for 5 to 7 days, taking note of how you feel, how you're sleeping, how's your anxiety, how's your pain, and then from there going up or down based on how you feel. But it has to be very slow, kind of like a gabapentin titration is what I tell my patients.
Now, when you say the 1-to-1, can that only be achieved with full spectrum? Is that what we're talking about there?
So a 1-to-1 is what you would find kind of if you go to a dispensary and you're looking for straight just cannabis products.
I see.
But full spectrum is not technically quite 1-to-1 because I have a 3,000 milligram full spectrum CBD oil. So a full dose is 100 milligrams of CBD, but the THC, right, 0.3% in that bottle is not a 1-to-1. So,
Wow. Okay.
yeah.
So essentially, over the counter, when people are ordering it from different companies, getting it at the gas station, as you mentioned, assuming
Right.
I mean, putting aside the contamination, purities, all the GMP, all that good stuff, that is in terms of what the data supports. That is not going to be efficacious for pain. That's what you're saying.
What is not?
In terms of pain control, like if you're just getting maybe a broad spectrum, full spectrum, or even a CBD
Oh, no,
isolate, because obviously you mentioned people for various reasons might not feel comfortable taking a full spectrum because whether they're getting tested, religious reasons, ethical, whatever it might
right.
be. So
No,
at least from what we know with the
CBD,
evidence.
yeah, CBD would still bind the CB1, CB2 receptors, but you're going to be missing out what they call the entourage effect, which is very
Mm,
important to mention, right? It's the entourage effect is the parts, the sum of the parts are greater than each of them individually. Kind of like what I tell people, it's, a symphony sounds great if you listen to all of the parts together, but if you just have a violin and a saxophone, it doesn't sound that good. But as soon as you start adding all these other instruments or all these other cannabinoids, it creates bigger conformational changes around those receptors and it works better. Um, and CBD isolate is better than no CBD at all, obviously within reason. But, full spectrum product works the best, and then a broad spectrum, and then isolate goes down from there. But low and slow, 5 to 10 milligrams once a week, change your dose. Um, and just kind of got to figure out where you're sitting in with that.
Awesome. All right, let's keep going down, right? So I think the next
Yeah.
best thing to talk about is just mood related disorders. Again, you talked about the
Yeah.
perception of pain and how that anxiety even building up, how it can amplify your experience of pain, right? So
Right.
where are we with mood related stuff, depression, anxiety, and any of those?
So again, no, I haven't seen any, peer reviewed double
Yeah.
blind crossover studies of CBD or cannabis for that. But just knowing where the receptors lie for the CB1 and CB2 receptors and CBD and THC binding to it, right? You obviously don't want too much THC because everyone that's smoked too much THC products will tell you they get more anxious. But it helps decrease sympathetic tone. It decreases amygdala activation, decreasing some of your perception of the anxiety. A lot of anxiety also is you perceiving the anxiety. It feeds into the anxiety, and then you go into this whole circle. And so, without going into any, I don't have any published data about it. I can just tell you where the receptors are located, and when the CBD binds it, that's if you're going to paint me into a corner, which a lot of physicians do, it's kind of where's the data? uh, I don't have concrete versus placebo data, but I can tell you anecdotally, it's helping patients. And, we use a lot of medications off label too that don't have all the published data that we have that we want for everything. Right. So I don't know.
Yeah, no, I think we can certainly appreciate that. I think it all starts with, does the science make sense? Which is kind of what we're talking a
Right.
lot about, right? I mean, I think we've kind of beat that
Right.
over and over and explaining it.
Right.
And so we have mechanistic understanding of how it makes sense. And then anecdotally, you're having good experiences, and you're not the only one. Obviously, there are a lot of people
Right.
who are doing it.
Right.
Just think about how popular it is. So that's, we've already touched upon. So in your practice, what is the primary reason that your patients are using it, like in terms of the volume of patients? Is it more for anxiety? Is it sleep? Is it pain? What are you primarily seeing?
Pain and sleep.
Pain and sleep. Okay.
Yeah.
Yeah. And okay, cool. And so I think that makes sense as well. We always talk about we had Patrick Finan, one of my friends here, who's a psychiatrist by training, talking about this bidirectional relationship between pain and sleep, and understanding now that impairments in sleep quality actually amplify the pain experience. And obviously, I think anybody who has a poor night's sleep, we're talking about how we're irritable, and again, we're talking pain, sleep, mood, they're all kind of tied in together.
Right.
Now, the other thing, and this is kind of where it gets a little tricky as people start talking about, when we start talking about the effects of cancer, right? And again, I know that's just a overarching big term, cancer. I mean, we can talk about different types of cancers and what that even means, or the benign, malignant, and different types of cancer. But when people talk about, oh, this helped cure cancer, and I put that in quotes, or this has helped in cancer treatments, what are people even talking about? Is anything related to CBD, THC, cannabis, anything that we know of
Yeah.
today?
Yeah.
You don't have to answer the question if you don't feel comfortable, because I know it gets a
Yeah.
little tricky there.
Yeah. Yeah. That gets a little tricky. And so, I think the biggest thing for cannabis that you can see, and not only anecdotally, but the evidence is the nausea associated with, the
Mhm.
chemotherapy, right? You need to eat, and a lot of these patients aren't eating because they're nauseous. So the cannabis can help with that. Now, cannabis in the term of treating and killing cancer, there are in vitro studies, right, in petri dishes where they're able to replicate certain cannabinoids that are able to quote unquote kill cancer cells. Now, that would be that's a great finding, right? There's some merit to that, but we all know in vitro does not mean in vivo, right?
Mhm.
So what happens in a petri dish is extremely a very, very far leap from what's going to happen when you ingest this with all the different factors inside of your body. So to say cancer, see, there, I mean, and I'll probably get flack from some of the people in the cannabis industry that I'm misrepresenting it and it does cure cancer and all that stuff. But you know what? I'm not going to go out and risk my professional reputation and my medical
Sure.
license on saying, use cannabis to treat your cancer. I think that's a very inappropriate and not a safe comment to make. But
Mhm.
um, there are some instances that people have used it. I've seen it. Um, you know, but I can't speak to any more about that. I don't know. I'm basically trying to allay myself around that question.
Yeah. No,
Yeah.
absolutely.
No, I
Absolutely.
mean, sorry, Darsh. No, what I will say is, so I actually, kind of just learning a little bit more about it. I came across a paper in Oncotarget in 2016 that talked about the potential of CBD being a pro-tumorigenic, and
Yeah.
particularly for colon cancer. And
Mhm.
mechanistically, they talked about how it activates the oh man, I hope I'm not getting this wrong. The CB2 receptors with submicromolar doses. And it becomes an agonist for CB2 and induces cell proliferation and favors the acquisition of molecular features in colon cancer cells. And
Okay.
now some of this, the biochemistry was beyond me. And I think I could probably, we can find the paper and link it in the show notes, but I don't know. Have you heard anything about that? And so, the flip side, the argument's there as well. So in terms of people trying to jump it down your throat, I mean, I think that would be kind of ridiculous, because this kind of goes back to the
Right.
idea that most of the stuff that we know in cancer treatment, Marinol, which is the synthetic CBD, is approved for a long time. Cancer related pain, that's what we're treating. We're treating the symptoms, right, by cancer, not necessarily the actual pathology itself. Does that make sense?
Right. No, I get that. You know, it's I think it's difficult because cannabis and CBD are under this microscope, right? And anytime there's anything good or bad, people elevate either one of those sides of the research, right? And I haven't seen that paper specific that you're talking about, but I have seen some stuff where people are like, oh, high dose of CBD can increase X or whatever the hell it is. But
Mhm.
um, you know, I don't know about that specific paper increasing cancer, but it potentially could, right? We still need more research on this, and it's still, but anything in medicine still needs more research, right? I guarantee if you were to look at, I mean, what's the research on aspirin and colon cancer? Right? Doesn't it go back and forth every year? Oh, it's preventative. Oh, it's not. You're gonna bleed out. I don't know, all that stuff. But
Mhm.
I think, I think it potentially could. I mean, I don't see any research that shows that it doesn't, or the research that shows that it does definitively, right? Um, I'm reading a whole paper right now about functional gut health disorders
Mhm.
and how cannabis helps with IBD, like colitis, and the way it works in the mesentery and the mucosal cells and stuff like that. But um, just knowing how CBD works in preferentially decreasing the uh, the white blood cells that are kind of overactive and actually kind of old and retired helps actually create apoptosis in them. Um,
Mhm.
you know, but I don't know. Are you killing too many cancer fighting cells? I don't know.
Right. Right.
I don't have a direct answer for that. That's a good question, but
Sure. And this is why we're young in the subject, right? I mean, this is where all the research is
right,
heading, and
right,
with every single organ system. So super cool
right.
stuff. I wanted to touch on Marinol that Ultimas just brought up, because I
Yeah,
remember being an intern, just starting residency. A lot of the cancer patients at the hemonc service, I'd see Marinol, and I'd be like, "Wait, what? We have weed in the hospital that we
yeah,
can
right,
give?"
right,
Right? So
right,
a lot of these newcomer doctors are pretty shocked. But little do we understand that it's actually just synthetic THC, correct? And it's not,
right,
because it's a full agonist, which I read in your book. It's not going to work the same as your organic THC that you would otherwise get from
right,
cannabis plant.
right.
Can you explain that a little bit?
Yeah, so Marinol never caught on because one thing that we continue to lack understanding of is that this plant is extremely complex and that you need the entourage effect, right? And
Mm-hmm.
so Marinol is a partial agonist of the CB1 receptor. The problem is there's no opposing CBD. So a lot of patients, I've written it before, and then the patients that take it, I don't know if whenever you wrote it, they're high, right? And they're like, either it doesn't work for them, but they're like,
Yeah.
man, I'm super stoned and it's not achieving what I needed to achieve. So screw this. It
Right.
never really caught on, but I was like, well, maybe I can write Marinol because it's a prescription, and then I can just give them my CBD, and then I created basically cannabis. But that's neither here nor there. But yeah, I mean, we try, right? We try to
Yeah.
dissolve everything, every red yeast, rice, and Lipitor, right?
Mm-hmm.
And
Yeah.
willow bark and aspirin, and
Right.
we try and dissolve everything down to its active molecule. But what happens if cannabis works just because it's super complex? I don't know.
Absolutely. Yeah. And I think
Right.
the only times now I really tried Marinol are for appetite. I've seen it work maybe
Right.
slightly in some patients that need weight gain. But otherwise, yeah, it's not really doing much when
No.
I prescribed it. So, but I will have a lot of
Right.
patients say, "Hey, can you give me some Marinol because I do take this cannabis at home, and given different hospitals regulations, you can't really prescribe the THC." Which now it's nice to think that at the institution that I work at, we're starting to allow patients to kind of bring in their own supplies if it shows to help. So
Oh,
yeah,
really?
yeah, yeah.
Oh, that's cool. For cancer patients or for every patient?
For anyone, yeah, as long as it's approved by the doctor, or like as if it's approved by the physician, and there's a need for it. So like a lot of IBD patients, like you said, or
Right.
some like crazy pain that we can't really put a pin on it. We'll allow them to have their home supplies. So
That's super cool, man. In Israel they give cannabis to their patients in the hospital. So yeah.
Awesome. Well, Charlie, I think it would be super important for us to, I mean, again, anytime in medicine, I think we all take the Hippocratic Oath. We always start with do no harm, right? So we've talked a lot
Right.
about the mechanisms. We talked about the therapeutic effects. This is maybe we could have led with this, but let's talk about the safety concerns, right? And some of the adverse effects that people do tend to experience. We touched on them here and there,
Mhm.
but what are common things that you'll see in your practice, but also reported, both common and also serious ones that people need to be
Right.
on the lookout for?
Yeah. Good question. So the research shows that there is a potential for liver enzyme elevation. That is published data, but it is a couple thousand milligrams a day. And the published data that they have, the LFTs did return to normal once the patient stopped the CBD. Um, Most commonly, and that's what I always worry about, right? If someone's already got NASH or they're already on a statin and their liver, potentially some liver issues, already kind of in the back of your head, you're like, all right, if this guy starts taking higher doses, we should probably get a CMP real quick just to make sure everyone's doing good. Most common reasons that people stop CBD and or cannabis is one, they don't like the feeling of it. Two, sometimes it's a headache. Stomach upset is kind of the biggest one, especially with higher doses of CBD. Patients get a little GI upset. And then, sometimes it increases their anxiety, which I've seen plenty of times. So like I said, CBD it's a biphasic molecule. Too much can make your symptoms worse. And so um, those are kind of common, but otherwise, like, cannabis and CBD are pretty well tolerated, if you're working with a knowledgeable medical professional that's going to sit there and walk you through this, right? There are potential, I don't know if you're going to touch on, drug interactions. I touched on it in my book and on my course. Anything that goes down the CYP 450, you know, uh, uh, lineage of enzymes in your liver, right? It can only digest so many things at certain times, right? And some of the drugs that we write are prodrugs that need to be digested in order to be active, right? And some of them need to be digested to be excreted. And now, if you're putting a bunch of CBD down this pathway, it may, put a car accident down there, and you may not be able to get all the stuff past it. So, again, low and slow. And sometimes if patients come in and their LFTs are elevated, is it due to the CBD? I don't know. But the two drugs that really concern me and that I always make sure that their prescribing physicians check with is any anticoagulant, specifically warfarin.
mhm.
Twofold, right? Warfarin is digested by the gut bacteria, and vitamin K can alter warfarin, and CBD alters the gut bacteria, and seizure medications, right? These are life sustaining medications. CBD is a life altering medication, it's not a life sustaining medication. So when I see those two medications on patients' list, I say, you're on warfarin. Who's writing it for your cardiologist? Make sure your cardiologist understands that we're taking CBD. We may get to higher doses, and to maybe take your INR maybe a little bit sooner than usual, or whatever it may be. But those are the two ones that always in the back of my head. I'm like, all right, you need to really make sure you're doing this correctly.
And then what about, issues like contamination, right? I mean, at this stage of the
Yeah.
game, I think for lack of a better word, I mean, I would say that since most people can purchase it over the counter or, at the
Uh-huh.
grocery store, almost like a supplement, right? And so you always worry about
Right.
different kinds of contaminations. We talked about the bad actors again. You only want the product that you're getting. You didn't sign up for any
Right.
additional things that might have adverse effects. So what are common things that you've seen? And we don't have to name any names here, but how do people sift that out?
So yeah. So on the back of the bottles or on the back of websites, there's usually QR codes that link you right to the right, to the lab results. But in the beginning, it was a lot of solvents. Sometimes there still is solvents, depending on how these people are pulling out the products from cannabis. They're using either CO2 extraction, they're using ethanol, they're using other types of issues. Sometimes, delta 8's a big thing right now. Delta 8 THC is not a natural occurring product, a cannabinoid. So they take CBD isolate, crush it with some type of chemicals, and make a delta 8 full of solvents. So the contamination stuff is a little bit better than it was, but also when you're smoking full flower, what people don't understand is the hemp plant actually recycles the earth and recycles the dirt. So if there's any contaminants in that soil that the hemp is growing in, it's going to suck it out and put it into the buds. And so it's very important when people are using smokable flower that the labs show pesticides, fungus, all these other types of things that you don't need to be concerned about an isolate or a full spectrum product because it's already been kind of distilled out. But a lot of that, and a lot of people that aren't putting the JAM article, I think of 2017 showed, how many people weren't actually putting CBD in their products, per labeling, or some of them were putting, it said just CBD and they had doses of THC that would get you really high. And, but by now it's pretty good, pretty reputable companies they're pretty spot on with what they're saying.
Yeah. I kind of want to transition here because a lot of our generation now is starting to get interested in becoming providers and licensed providers for cannabis.
Right.
The functional medicine doctor that I've worked with over the past year is doing the same. And I know there's a process behind it. Can you kind of explain what the process was that you took to become a licensed provider?
Yeah, so in the state of Arizona, PAs were left off the bill, so I can't technically recommend cannabis. So I've kind of built it up where doctors write for it, recommend it, and then the patients find me to coach on it.
I see.
And so basically every state has its regulations based off of what you need to be competent in. And the company that I recommend, I get no money from this, is Medical Marijuana 411. It's I usually have the textbook on my desk. It's a extremely good course, like specifically for medical professionals. It's a thick textbook with online modules, and it meets certain states' criteria, right? That you have to just do so many hours of studying or whatever, and that's basically it, right? It's almost like Suboxone.
Gotcha.
If you want to get your X waiver, you can just sit through the course for what is it, 10 hours or 5 hours, whatever it is. But that's it, and then kind of just really. But you got to think people that are finding this field really are interested in it, so they're going to self-educate too on top of the minimum requirements. And so, just trying to make sure that there's a lot of good information out there.
Gotcha. And you have your own course, so speak on that.
Yeah, it's not, it doesn't certify anybody. It's just kind of during COVID, I was bored, and so I wrote my I wrote my book, and my wife was like, "Oh, you're bored? Why don't you make a course?" And I was like, "That's actually a really good idea." And so I made the course, one for the like more lay people and one for more medical professionals, just to try and help people kind of make sure that they're getting, even today, you still go on some of the websites of these CBD companies, some of the stuff they're saying, you're like, you can't say it's going to cure your cancer. You can't say it's going to cure this, right? Like they're just saying bad stuff. So I'm trying to make sure patients and other medical professionals get legitimate information. All my stuff is, you read my book. I have all the footnotes for all the PubMed articles that I used for it. So, my course is kind of just a combination of the book, and I fill in some more gaps.
Awesome. Well, I signed up for the course. Can't wait to start that. And your book is phenomenal. So providers out there, even patients, it's not a long read, right? I mean, it was engaging. I learned a lot from it. And if you guys are liking this podcast episode so far, it's definitely a book to have, so you don't have to keep rewinding this episode. You'll have it at your fingertips. So Charlie, future of cannabis, where is it heading? What are you excited about?
Yeah. Great question. I foresee, so I'll break it down to two things. I foresee CBD becoming like the craft beer market. I think a lot of coalescence of big companies are going to come in, and kind of, you're going to have regional companies, people maybe like my product are going to the Southwest, and not much people in Maine or whatever like it. Cannabis is going to become legal. I mean, if you look at the popular opinion, it's shifted even more and more in favor of it. I think the federal government's just trying to figure out how they're going to regulate it and tax the crap out of it, which is fine. At least people are getting legitimate products. And so I think the next 5 to 10 years are going to be super exciting. And even, we need, this is coming from someone who believes in it. We need more research. We need more, double-blind, placebo-studied research in order to really validate what I'm seeing every day and what I'm sure some of you guys see in some of your patients. But I always get pinned to the wall by other providers like, well, where's the data? I'm like, I
Yeah.
don't have the data, right? It's still considered a less, C1. So, but like
Right.
you guys said, we took an oath, do no harm. And if it's a very, there are some potential side effects of this, but if it's on a relatively harmless
Sure.
plant,
Right.
so
Like
yeah.
there is for alcohol, right? I mean, we've got control studies on
Oh God,
alcohol.
yeah.
So, and is it true there's been 0 deaths from marijuana, like solely from the plant itself, not in like,
Yeah.
driving and things
Yeah.
like that?
Yeah.
So,
So 100%. So there are no CB receptors on the brainstem, right, that control your respiratory drive. So
mhm.
there's no reason. I mean, when mostly the people that overdose from opiates, right, they usually are aspirating or they just stop breathing. And so with cannabis, there's no receptor. You have to smoke. I think I'm going to get the number wrong. It's like 40,000 joints in like 10
Oh my
minutes. You would
gosh.
basically pass out before you did it, right? And it'd just be some type of So there's no deaths, but I tell it like I want to hammer home. I don't want people to think, oh, there's a provider giving cannabis is good for everybody. It needs to be the right dose for the right patient for the right ailment, right? It needs to be done in a controlled manner as much as you can. Just don't go smoking weed until you get high and think there's no ramifications, right? There are
Right.
potential side effects of these medications,
Right.
of this plant.
Awesome. Well, Charlie, I know people are going to want to learn more.
Yeah.
Where do they find you? What's your website?
Yeah. So my company, RestorativeCBD.com, you can purchase CBD products. I have some of my podcast up there too. My podcast is medically assisted CBD. And then I have my cannabis coaching company is RestorativeCannabisCoaching.com. Pretty similarly linked to each other, but yeah, I'm more than happy to help people out. If other medical providers, I get a lot of phone calls from doctors such as yourself, like, hey, where do I start or what do I do or, what it is. And always down to help, other professionals make sure that this industry is getting a getting a good name and people are actually respecting it.
Awesome. Well, Charlie, I want to thank you for your time, for coming out and
Yeah.
educating us. I think that this has been a highly informative conversation and probably opens up a lot more questions for the inquisitive mind, at least. And I think that's what any good scientific discussion is supposed to do. And
Right.
I don't think that will convince anybody. And I don't, again, I don't think that's the intention here. I think we want to inform people and then they make decisions on themselves. Also, there's
100%.
nothing on here is medical advice. So just remember that this is
Right.
just all for educational purposes only. But before we let you go, man, we do want to ask you this important question because that is kind of the mission of our show here is how do we add the health back to healthcare?
Oh God, how much time you got? And so you guys obviously had my mentor and my good friend Dr. Patel in here, who has molded kind of my approach to medicine and how to get health in the back into healthcare. Man, it's simple, right? If you follow Dr. Mark Hyman, food is medicine, and movement is so important. And putting this phone down and talking to one another and having dinner with your family. I mean, I think they just came out with an article about having dinner with your family produces, right, so many benefits. And we don't need gigantic hero medicine, right? We don't need to
Right.
put statins and stents in everybody. If we actually talk to patients about, hey, why don't we move a little bit? Why do Italians drink wine and eat a lot of pasta and pizza when they live healthier, longer lives, right? Look at the quality of their food. They walk more places, right? I'm talking, old school, in the hills and stuff, but it is a complex issue, but start with simple issues, right? Low hanging fruit, exercise more, sleep better, eat better food, you know, easier said than done, I guess.
Simple, but not easy.
Yeah.
I agree.
Right.
Well, I love it. Thanks, Charlie. Thanks for your time.
Thank you.
Yeah. Thanks for having me, guys.
All right. Thanks for tuning in to another episode of Medicine Redefined, and this time with our guy, Charlie Piermarini, expert in all things cannabis. What an awesome conversation for me. I mean, I thought I knew a lot about cannabis already, but Charlie just took it to another level, and I just became 10 times smarter understanding THC versus CBD and its effects and essentially the mechanism of action. And I hope you guys all took away something as well. This is a very important conversation that we need to start having. I know a lot of us are probably already starting to talk about CBD and THC, and it can be scary to bring up to our parents or to our kids or to our friends. And a lot of us are afraid to be judged, especially as it's starting to become legalized, but it's still a Schedule 1. But hopefully this episode kind of clarified a lot of the things you were thinking about. And I think the most important thing we can all do right now is to share this episode. Share it with your family, share it with your friends, share it to whoever you are having those conversations about cannabis with. Because we need to start understanding that CBD and THC and all these molecules might actually be helping us more so than the opioids that we are prescribing at a horrific rate. So go ahead, share this episode, and let's provide education to everyone. Now, before we end, here's a quick reminder. If you want to boost efficiency across your practice and make staff scheduling easier, try the Deputy app. You can try this smart technology for free by going to drpodcastnetwork.com/deputy. That's drpodcastnetwork.com/deputy. Disclaimer, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. And again, thanks for joining in. If there's one thing we can ask you to do, please hit that subscribe button. If you are listening on Apple Podcasts, in the top right-hand corner, you will see a plus sign. If you're on Spotify, I think it's pretty evident. But again, we are not only limited to those two platforms. You can hear Medicine Redefined across all different platforms. Until next time.